We're going to continue on with the electrical activity of the heart. So the pattern of contractions in one heartbeat is called the cardiac cycle. And we want the atria to contract first. They will finish filling up the ventricles, and then we want the ventricles to contract second. So the electrical activity in the heart will control that contraction pattern. So I just have a couple of animations. The first one is just a realistic looking animation of a heart beating if you want to watch that. And then this next one is just a really nice tutorial on the heart that you might want to check out at home. There are three different types of cardiac muscle cells. There's pacemaker cells, conduction fibers, and contractile cells. And in this picture on the bottom, you can see there's a bunch of contractile cardiac muscle cells that makes up most of the myocardium. And then these Purkinje fibers, these are actually conduction fibers. They're going to take the action potentials generated by the pacemaker cells and deliver those to the contractile cells to make them contract. So the pacemaker cells, they are autorhythmic cells, so they are able to just spontaneously depolarize and generate their own action potentials without anyone telling them to do that. So they're going to set the heart rate or the pace of the heart. Where the pacemaker cells are located, we have the SA or sinoatrial node, which is in the top part of the right atrium. And that's the pacemaker of the heart, so it's going to set the heart rate. The other pacemaker cells are located in the AV or atrioventricular node, and that's kind of in the bottom corner of the right atrium here. The AV node is actually generating action potentials but at a much slower rate. So the SA node generates action potentials much faster, and so it usually will set the heart rate. But if the SA node was damaged, the AV node is a nice backup system and will take over and set the heart rate, but it'll be a much slower rate. The conduction fibers are just going to conduct the action potentials that were generated by the pacemaker cells, and they're going to take them to the contractile cells that are actually going to contract and pump the blood. And there's gap junctions in those intercalated discs between the all of the cardiac muscle cells, so the action potentials will just travel through the conduction fibers rapidly through those gap junctions. And then most of the cardiac muscle cells will be the contractile cells, and they're the ones that are actually going to contract, generate the force, and pump the blood. And then just to answer the question on the bottom, what is the pathway of action potentials? So remember, they're going to start in the pacemaker cells, and then they're going to go through the conduction fibers and be taken to the contractile cells, which will then contract and pump the blood. So here's just a picture showing the SA node here, setting our heart rate, generating the action potentials spontaneously. So those action potentials will then travel through the cardiac muscle cells, and it travels through these gap junctions located in the intercalated discs. So let's follow the action potentials from the SA node through the conduction system of the heart, and it'll be easier if we just look at a picture. We're going to start in the SA node. The pacemaker cells there will spontaneously depolarize, generate their own action potentials. The action potentials will then be sent to both atria, and the atria will contract and finish filling up the ventricles. The action potential gets to the AV node, and there's an AV nodal delay. The AV node is slow to pass the action potential through there. There's like a 0.1 second delay. And that AV nodal delay is actually very important because it's going to allow the atria to contract first, finish filling up the ventricles, and then the ventricles contract second. If you didn't have that AV nodal delay there, the atria and ventricles would be contracting at the same time, and that would not work because the atria could then not finish filling up the ventricles while the ventricles are contracting. So after the AV nodal delay, The action potential is going to travel down through this interventricular septum between the two ventricles. And when it goes from the AV node before it separates into two branches here, this pathway here is called the bundle of His, and it's just named after the scientist that discovered it. So from the AV node, action potentials go through the bundle of His, and then the conduction fibers are going to branch into these bundle branches. There's a right and a left bundle branch, and those will take the action potentials towards the apex of the heart, and then at the apex of the heart, we'll send the action potentials up the walls of the ventricles on both sides through what's called the Purkinje fibers. And the action potentials going up through the Purkinje fibers will then cause the ventricles to contract. The ventricles contract starting at the apex, the bottom here, and then they will squeeze the blood out through the semilunar valves, and it's kind of like squeezing a tube of toothpaste from the bottom. So that allows to get more blood out if you start contracting at the bottom. And then this is just another picture just showing you the conduction system of the heart, just showing you that the action potentials start in the SA node, our pacemaker. The action potentials then spread to both atria. The atria contract. We've got that AV nodal delay that allows the atria to contract first before the ventricles contract. And then the action potential goes down the bundle of His, and then down the right and left bundle branches, and then it will go up the walls of both ventricles through their Purkinje fibers, and then the ventricles contract. So looking at the electrical activity in the pacemaker cells, so remember these are in the SA and the AV nodes. They will just spontaneously depolarize and create these pacemaker potentials, which are graded potentials, and then that will trigger an action potential to occur in the SA and AV nodes. I will go through a picture of this next, but just to fill in our blank here, remember that when we have action potentials in neurons and also in skeletal muscle, remember that repolarization is due to potassium moving out the voltage-gated potassium channels. So that fills in the blank there. Repolarization is due to potassium moving out through the voltage-gated potassium channels. And then here's just a picture of the action potentials that occur in the pacemaker cells that are in the SA and the AV nodes. So they don't have a steady resting membrane potential at all, like we're used to seeing. So here we have at minus 70 millivolts, our membrane potential. We're going to be opening up what are called funny channels. So it's kind of an odd name, but the reason they're named that is because most voltage-gated sodium channels, remember that they open when you reach threshold, you get more positive, and then that triggers them to open. Well, the funny channels are voltage-gated sodium channels that are funny because they open when the membrane potential is more negative instead of positive. So down here at minus 70 millivolts, we're going to trigger the opening of the funny channels, which are just a type of voltage-gated sodium channel. Sodium will come in, that will make the membrane potential more positive. And then at minus 55 millivolts, the funny channels will close, but we haven't reached threshold yet at minus 50 millivolts. So at minus 55 millivolts, another type of voltage-gated channel opens here in green. And these are called T-type voltage-gated calcium channels. So T stands for transient, just saying that they're not going to be open for very long. So these T-type voltage-gated calcium channels are just open from minus 55 millivolts up to minus 50 millivolts when you reach threshold. So they allow calcium to come in, and that makes it more positive. And then the pacemaker cell reaches threshold, and then we're going to generate our action potential. So all of this getting from the minus 70 millivolts up to threshold at minus 50 millivolts, this is called the pacemaker potential. And the pacemaker potential is just a graded potential like we've talked about before, so same idea. And then once we reach threshold, then we're going to trigger the opening of some L-type voltage-gated calcium channels. And calcium will rush in, make it more positive inside the cell, and cause the depolarization phase of the action potential. So this is really different from what we talked about before. So remember that in neurons and skeletal muscle, what causes the depolarization phase of the action potential is when voltage-gated sodium channels open. But here in the pacemaker cells and the SA and the AV nodes, the depolarization phase is going to be caused by calcium coming in through the L-type voltage-gated calcium channels. And the L just stands for long-lasting, just saying that these type of voltage-gated calcium channels stay open longer than the T-type, which are the transient ones. And then at the top, we're going to close the L-type voltage-gated calcium channels, and then we're going to repolarize by opening up the voltage-gated potassium channels, which is very similar to what we talked about in skeletal muscle and in neurons. So as potassium leaves the cell, it becomes more negative, and then we go back down to minus 70 millivolts, but notice we don't have a nice steady resting membrane potential, because when you get down to the minus 70 millivolts, we're going to trigger the opening of the funny channels again, and then we start with another pacemaker potential. And then this is just a picture from your book, just what we drew out. So the action potentials that we see in the contractile cells, which are different than the pacemaker cells. Remember, the pacemaker cells are in the SA and AV nodes. They're going to be spontaneously generating these action potentials, starting the heart to beat. The contractile cells are the majority of the cardiac muscle cells, and when they get the signal, the action potential coming through the gap junctions, that'll trigger an action potential in them, and then they will go ahead and contract from that. So let's just take a look at a picture to see what the action potential looks like. This is the action potential that occurs in cardiac contractile cells. It looks very different than what we saw in the pacemaker cells. So their resting membrane potential does stay steady, and it's lower than what we've seen before in neurons and skeletal muscle. It's sitting here at minus 90 millivolts. So when the action potential comes through the gap junctions into these cardiac contractile cells, that will trigger the opening of the voltage-gated sodium channels, and then we will cause depolarization as sodium comes into the cell. And then at the top here, the voltage-gated sodium channels will close. And then as they close, since sodium's not coming in anymore, the membrane potential starts to drop a little bit. And then we get this plateau. And this plateau is really important in the action potentials in these contractile cells. What causes this plateau is the opening of some L-type voltage-gated calcium channels. So calcium comes in, makes it more positive, and so it prolongs the repolarization phase. It's going to take longer for the contractile cell to repolarize. So that's important for a couple of different reasons. One is that having this plateau and making the action potential last a really long time in these contractile cells, that makes the refractory period really long in these contractile cells. And that's why you cannot add the muscle twitches together in the cardiac contractile cells, because the refractory period is so long. So there's no way you can get tetanus in cardiac muscle, which is really good because you don't want the cardiac muscle just to keep contracting the whole time. You need it to contract, relax, so you can refill the ventricles with blood. The other thing is that the calcium that's coming in, we will use some of that to bind to the troponin and lift the tropomyosin out of the way, so then we can do our cross-bridge cycling. And at the end of the plateau here, we're going to be opening up our voltage-gated potassium channels. Potassium moves out, and that'll cause repolarization. And then this is just our picture from the book. And this is just to point out that the action potential that is occurring in these contractile cells and the cardiac muscle cells are really long. And here's the muscle twitch. So the cardiac muscle is contracting and then starts to relax. And you can see the refractory period lasts almost the whole length of the muscle twitch. So by the time you're out of that refractory period, you can generate another action potential in the contractile cell. That first twitch is pretty much gone, and so you won't be able to add the twitches together, and there's no way that you can get tetanus in the heart. So excitation and contraction coupling in these contractile cells that are going to contract and pump the blood. Let's just take a look at a picture. So the action potentials will come through the gap junctions. Some of the sodium and calcium ions will flow through, and then that'll trigger an action potential to start in the next contractile cell. And the action potentials will travel down the T-tubules in the contractile cells. That'll trigger the release of calcium from the sarcoplasmic reticulum. And then in cardiac muscle cells, we don't have quite enough calcium from the sarcoplasmic reticulum, so we also will use calcium coming in from those L-type voltage-gated calcium channels that cause the plateau in the action potential in the contractile cell. The calcium will then bind to the troponin, which will lift the tropomyosin rope out of the way. That'll allow the myosin heads to bind to the thin filaments, and we'll do the cross-bridge cycle just like we talked about in skeletal muscle, and we'll shorten the sarcomeres, and that will cause the heart to contract and squeeze the blood out. And then for the cardiac muscle to relax, we just need to get rid of the calcium. So we'll put it back in the sarcoplasmic reticulum, and then we can also pump it back out into the extracellular fluid. We can record the electrical activity of the heart by using an electrocardiogram, which is abbreviated in ECG or EKG. So the ECGs will be used to detect any abnormal electrical activity in the heart, which are called arrhythmias. So your patient, maybe they're skipping a beat, maybe their heart rate's too fast, too slow. You can pick up all of that on the ECG. One thing to keep in mind with the ECG is that the recording that you're looking at is not an individual action potential. It's looking at all the action potentials that are occurring in the heart right at that moment. So we use leads to pick up the electrical activity from the heart. It's actually transmitted through the skin, and so we can pick that up with our ECG. So this is called Einthoven's triangle. You do not have to memorize this, but it just shows you the angle that we look at the electrical activity in the heart. So for example, if you're looking at lead 2, that's over here on the left, we're going to look at the electrical activity of the heart from the viewpoint where the left leg is the positive pole, and then the right arm is going to be the negative pole. So they're just different angles, different ways to look at the electrical activity, and you get some different pictures. You do not need to memorize any of these leads. This is a picture of the normal tracing that you would see on an ECG. So make sure you star this. This is really important to know what each of these waves and complexes is indicating. So the first wave that we see, this little one here, that's called the P wave. So the P wave is just showing you that the atria are depolarizing. So the P wave indicates atrial depolarization. And then hopefully the atria will contract after that. The ECG does not indicate whether or not the heart is contracting or not. You'd have to listen with your stethoscope to hear the heartbeat, but it just indicates that the action potentials went through the atria, and then hopefully they did contract after that. So P wave, that is atrial depolarization. And then the QRS complex, this tall spiky thing. So the QRS complex indicates ventricular depolarization. So the ventricles are depolarizing, and then hopefully they would contract. And then the last wave is the T wave. And the T wave indicates the ventricles are repolarizing. So the T wave is ventricular repolarization. You don't need to know any of these other intervals that are up here. You can actually take a whole class on reading ECGs, and you definitely will learn that there later on in your healthcare classes. But one thing just to point out, this P to Q interval. Notice that there's a delay between when the atria depolarize and then when the ventricles depolarize in the QRS complex. So this P to Q interval is actually showing you the AV nodal delay. So remember that we want the atria to contract first and then finish filling up the ventricles and then the ventricles to contract. This is just showing you the leads that they place on people. There's up to 12 leads that they could look at. So here are just some examples of some ECG readings. It's important to know what a sinus rhythm is. So a sinus rhythm is normal. Sinus just is saying that the heart rate is being generated by the SA node. Okay, because remember the SA node is called the sinoatrial node, so that's where the word sinus comes from. Here's some rates that are abnormal. They are sinus rhythms because they are coming from the SA node, so you will see the nice P, QRS, and T waves. But what's happening in this middle one is that we have tachycardia. So tachy meaning fast, so it just means that the heart rate is too fast. So you can actually see if you go from one R to the next R to the next R, you can actually count a heart rate by doing that, and so you can see that the heart rate is going to be too fast compared to the one that's up here. The one on the bottom is another sinus rhythm because you do have a normal P, QRS, T, so this is all being generated by the SA node. But now our heart rate is too slow. So bradycardia, brady means slow, so that means a slow heart rate. And then here's a normal ECG tracing here, but down on the bottom, this is really bad if you see this in your patient. So you can see that there are no P, QRS, Ts anywhere. So the SA and AV node, they are not working. And what happens is that the conduction fibers and the ventricles, the Purkinje fibers, they take over, but they're all generating action potentials at different times, and so all the contractile cells in the ventricles are all contracting at different times, and so the ventricle just sits there and it shakes or fibrillates. And so your ventricle is not actually pumping the blood around, and so this person is going to die very quickly unless you do something about it. So what they do to correct ventricular fibrillation is they will use a defibrillator. So you probably have seen those, and you may even know how to use those. So they'll put the paddles on the person's chest and send an electrical shock through the body, and then that will hopefully reset the rhythm and get the SA node working again.